World Medicine Universitet. 2017. Treatment of acne scars. While the previous chapters have dealt with the pathophysiology and treatment of acne vulgaris, this chapter is devoted to the treatment of one of the more unfortunate and yet frequent consequences of the condition, namely scarring. Acne scars can cause significant physical and psychological disability, especially since they, like acne vulgaris, commonly occur during the teenage years. In recent years, the field of skin resurfacing and rejuvenation has truly blossomed, offering multiple treatment options where few, if any, existed before. Today's treatment modalities offer reliable, predictable, and reproducible improvement in acne scars. This chapter will offer an in-depth look at the various commonly utilized therapeutic options. However, as the field continues to grow rapidly and expand, the specific equipment and system settings may become outdated or obsolete. Thus, the information is presented with the emphasis on the broad biophysical concepts, as well as on organization and classification of technologies, rather than on the specific treatment parameters for the systems available today. Classification of acne scars. Acne scars vary significantly in their morphology, and a proper classification system is, therefore, important. Many such systems have been developed over the years. However, some are more suitable for descriptive purposes only and cannot be directly and consistently applied to the selection of specific treatment modalities. One of the most therapeutically useful classification schemes has been proposed by Jacob et al. Accordingly, atrophic acne scars are subdivided into icepick, rolling, and boxscar varieties. Boxscar scars are then further differentiated into shallow and deep subtypes. On the other end of the spectrum, keloid and hypertrophic scars result from excessive scar tissue formation. 37. They occur less frequently than atrophic scars and are more common on the trunk rather than face. Table 3. Icepick scars are typically narrow, sharply delineated tracts that taper to a point as they extend to the deep dermis or subcutaneous tissue. 38. Rolling scars are broad-based skin surface depressions with a resulting undulating appearance. 39. They are formed by the tethering forces derived from abnormal fibrous adhesions of the dermis to the superficial musculopneurotic system. Finally, boxscar scars have a round or oval shape, appear to be punched out with a broad, relatively flat base and vertical edges, and are either less than or greater than 0.5 mm in depth, classified as shallow and deep varieties, respectively. 40. As previously mentioned, the differentiation between these subtypes of scars may help to guide the practitioner in the selection of the most appropriate and efficacious therapeutic modality. Since the apex of the icepick scars frequently extends beyond the depth of penetration of most resurfacing tools, a punch excision is usually undertaken prior to resurfacing. Tethering forces that account for the appearance of rolling scars need to be released using subcision in order to achieve the best clinical results. The relatively normal, but depressed, skin at the base of deep boxscar scars may be properly repositioned using punch elevation techniques. Finally, the shallow variety of boxscar scars and similarly appearing varicella scars may be improved with the help of various resurfacing modalities without any pre-treatment. Since patients may exhibit many of these varieties of scars simultaneously, multiple techniques are frequently combined. These techniques will now be examined in depth. Surgical options: punch excision, subcision, punch elevation. Although other techniques, such as punch grafting and dermal planing, have been utilized for the correction of scars, punch excision, subcision, and punch elevation are the most commonly utilized surgical treatment modalities and will be discussed here. Punch excision is best reserved for ice pick scars, as well as for some narrow, deep boxcar scars. Following local infiltrative anesthesia, an excision down to fat is performed using a disposable round punch tool. The diameter of the punch tool should match the diameter of the scar, including the walls. If the scar measures more than 4 mm in diameter, an elliptical excision may be preferred to a punch excision in order to avoid dog ear formation. The scar is then removed, and the wound is repaired in a usual, everted manner using a single suture. 41-43. A standard dressing, typically consisting of an antibiotic ointment and a bandage, is then applied to the wound. Additional scars may be excised on the same day, as long as they are spaced at least 5 mm apart to prevent undue tension on the wound. The patient is then instructed on local wound care. The sutures are removed 5-7 days later, thus preventing the appearance of track marks. Resurfacing, as described later in this chapter, may then be used 4-6 weeks later to achieve an even less conspicuous appearance of the scars. The technique of subcision, or subcutaneous incision, was first developed by Orantriak and Orantriak. This procedure is most useful for rolling scars, which result from fibrous adhesions of dermis to deeper structures. 44. In the process, such adhesions are released, allowing for the otherwise relatively normal skin to assume a more relaxed, non-tethered appearance. A triangularly shaped 18-gauge Noker admix needle may be used for the procedure. 45. The needle is first attached to a 1 ml or 3 ml empty syringe, and the position of the slanted cutting edge of the needle is noted in relation to the markings on the syringe. Alternatively, a corresponding mark may be placed on the syringe using a surgical marker. Once the needle is inserted under the skin, this will serve to guide the needle in the proper direction of movement. Infiltrative anesthesia is then achieved, and the needle is introduced horizontally near the edge of the scarred area. Once the needle reaches the subcutaneous fat, the syringe is used as a handle to locate and, with a gentle back and forth motion, to cut the fibrous bands. As previously mentioned, care must be exercised at all times to ensure that the cutting edge of the needle is horizontal, that is, parallel to the skin surface and facing the adhesions. The needle is then withdrawn and the wound is covered with an antibiotic ointment. No suturing of the wound is necessary. Finally, a pressure dressing is applied over the entire undermined area to reduce the risk of bleeding and hematoma formation. In addition to bruising and rare infection and bleeding, adverse effects may also include nodule formation from excessive fibroplasia, which frequently resolved spontaneously or may be treated with an intralesional steroid injection. Multiple sessions of subcision are sometimes necessary. In addition, other techniques, such as filler material injections or laser resurfacing, may be used in conjunction with this procedure to achieve the best clinical results. Punch elevation works best for deep boxcar acne and varicella scars, where the walls extend vertically down to the relatively normal base. Following local infiltrative anesthesia, a disposable punch tool, selected to match exactly the diameter of the scar, is used to incise the skin to the level of subcutaneous fat. 46. The resulting tissue is then elevated to just above the level of the surrounding skin to account for subsequent retraction. Sutures, stree strips, or a 2-octyl cyanoacrylate skin adhesive is then used to affix the tissue in place. An antibiotic ointment and a non-stick dressing are applied to the wound and the patient is instructed on the proper gentle wound care. If sutures are utilized, they are removed after 5-7 days, while resurfacing may be considered after an additional 4-6 weeks. Dermaroller. Dermaroller, also known as microneedling or percutaneous collagen induction therapy, has been gaining popularity for the treatment of scars due to the ease of use, low incidence of adverse effects, and low cost. Though large prospective studies are lacking, significant retrospective and smaller prospective studies suggest efficacy in the improvement of acne scarring. A typical dermaroller is a single-use plastic cylindrical roller studded with microneedles ranging from 0.5 to 3 mm in length and 0.1 mm in diameter. In addition, smaller versions, known as dermastamps, have also been introduced for smaller scars. Using the dermaroller 15 times over the same area has been shown to result in approximately 250 microperforations per cm2. This, in turn, leads to new collagen and elastic fiber deposition in the subsequent wound healing process. Thickened epidermis has also been demonstrated following this procedure. Studies suggest good to excellent improvement, especially in mild to moderate rolling and boxcar scars, and significant objective improvement using both the Vancouver Scar Scale and the Patient and Observer Scar Assessment Scale. Prior to treatment, an anesthetic cream is applied to the skin. Rolling is then performed 15 to 20 times in vertical, horizontal, and diagonal directions. Deep scars should be stretched to allow the needles to penetrate the base of the scar. Immediately following the procedure, damp gauze or pads are applied to the area to absorb serous oozing and to facilitate healing. Adverse effects may include erythema, typically lasting 2-3 days, mild to moderate edema, and bruising for approximately 4-7 days, and crusting for 1-2 days. Cases of herpes simplex infection and rare transient post-inflammatory hyperpigmentation have been reported following microneedling. 3 to 4 sessions, performed every 4-6 weeks, are typically required to achieve the best clinical results. Chemical reconstruction of skin scars technique. A novel technique of focal chemical treatment of acne scars has been introduced by Lee et al. This modality, called chemical reconstruction of skin scars method by the original authors, can be very effective in the improvement of the various types of deep acne scars. In the process, a high concentration trichloroacetic acid, usually between 85% and 100%, is applied focally to the scars. When applied to the skin, lower concentrations of TCA, up to 35%, are known to cause protein precipitation, manifesting as frosting and resulting in coagulative necrosis of the epidermis and collagen degradation down to the upper reticular dermis. Subsequent collagen remodeling and reorganization of dermal structural elements as a result of wound repair processes then lead to an augmentation of dermal volume. Although chemical peeling using high concentration TCA may lead to scarring and is, therefore, strongly discouraged, focal application of the chemical localized to deep acne scars appears to be safe and effective, even in darker skin types. This is likely the result of epidermal sparing, including that of adnexal structures, in the surrounding, untreated skin. Clinically, a gradual elevation of the scar is observed over several months, while histological evidence of immediate coagulative necrosis with subsequent increased epidermal and dermal thickness, increased collagen content, and reorganization of abnormal elastic fibers has been demonstrated. Prior to treatment, the affected skin is thoroughly cleansed with alcohol or acetone. No anesthesia is typically necessary, as the mild focal burning or stinging sensation is well tolerated by most patients. The chemical is then applied to the base of the scar using firm pressure with a sharpened wooden applicator with a slightly dulled tip until white frosting is observed, typically around 10 seconds. The procedure is then repeated to cover the entire depressed area. No post-treatment neutralization of TCA is needed, but a topical antibiotic ointment is applied to the wound without an occlusive dressing. Patients are then instructed on local wound care, typically consisting of mild cleansing and the application of an antibiotic ointment, as well as on strict sun protection. It is important to discuss the expected postoperative appearance of the treated areas, with the typical progression of colors from white to gray to brown-black and subsequent desquamation. Common adverse effects of the procedure include mild erythema lasting up to 8 weeks, transient post-inflammatory hyperpigmentation lasting up to 6 weeks, and mild acneiform eruptions. On the other hand, no serious or long-term complications, such as persistent dyschromia, herpetic reactivation, or scarring, have been noted in studies. Of note, 2 patients with a history of recent oral isotretinoin intake were treated in one of the studies without subsequent development of keloids, although the small number of patients precludes a definitive statement on this matter. Multiple treatment sessions are often necessary in order to achieve the best clinical improvement. The procedure may be repeated every 4-6 weeks. Injectables in the treatment of atrophic acne scars. Soft tissue fillers have long been used for a multitude of cosmetic applications, most notably ridded correction and facial contouring and augmentation. Various injectable filler materials have also been used for the correction of atrophic acne scars, both singly or in conjunction with other treatment modalities discussed in this chapter, 47,48. It should, however, be noted that the use of all injectable fillers for the improvement of acne scars is considered off-label in the U.S. Currently available fillers may be divided into permanent and temporary ones. Examples of permanent fillers include silicone oil, autologous fat transfer, polymethyl methacrylate, as well as a polyacrylamide hydrogel filler currently available outside the U.S. Examples of materials used in temporary fillers include collagen, hyaluronic acid, calcium hydroxylapatite, and poly-L-lactic acid. Prior to treatment, the practitioner should be thoroughly familiar with the specific filler selected for this application, including its proper placement, duration of action, and potential complications and adverse effects. These are discussed at length in numerous review articles and will not be covered in this section, as new products are constantly being developed. Proper patient selection is of the utmost importance, as ice-pick scars tend to resist treatment with injectable fillers. Rolling acne scars may require subcision to release adhesions prior to injection, while boxcar scars tend to fare the best with this approach. A useful technique is the pinch test, in which the scar is pinched between the thumb and the index finger. Partial correction indicates a possibly successful outcome, whereas the absence of correction or deepening of the scar secondary to tethering from the underlying adhesions indicates a likely failure of this type of therapy. In addition, active inflammatory or infectious condition at the intended treatment site is a contraindication to filler placement, while the use of anticoagulative agents increases the risk of bruising. Multiple angle, High-quality photographs should be obtained prior to treatment, and tangential lighting may be used to document the depth of the scars. If required, anesthesia may be achieved with topical anesthetic agents or with nerve blocks. Infiltrative anesthesia should be avoided to prevent distortion of the treatment area. The filler is then placed underneath each acne scar at the proper depth for the individual product. For larger scars, serial puncture, linear threading, and fanning techniques, or a combination thereof, may be used to achieve the best correction. Depending on the specific injectable product, under or overcorrection may sometimes be necessary. Ice packs can be utilized post-operatively to decrease swelling and bruising. If needed, additional treatment sessions may be performed in 2-4 weeks. Lasers and laser-like devices, traditional ablative resurfacing. Traditional ablative devices used in the resurfacing of acne scars include carbon dioxide and erbium yttrium aluminum garnet lasers. More recently, an erbium yttrium scandium gallium garnet laser, emitting light at 2790 nm and with the depth of ablation between those of CO2 and YAG lasers, has been added to the lineup of ablative lasers, though its specific role in the treatment of acne scars will need to be established in future studies. In addition, a plasma skin resurfacing 3 device has also received FDA clearance for this indication. Skin ablation results from the evaporation of water and subsequent tissue desiccation. Both the CO2 and YAG lasers utilize specific absorptive properties of the water molecule, whereas the plasma skin resurfacing device delivers nonspecific thermal energy to the epidermis, which is then propagated to the upper dermis. Originally, the improvement associated with cutaneous resurfacing was mainly attributed to the ablation of the superficial skin layers. Today, however, thermal diffusion to the dermis, also known as residual thermal damage, with the resulting collagen denaturation and subsequent wound remodeling are thought to form the basis for such an improvement. Collagen fibril is a right-handed helix with 3 polypeptide chains held together by hydrogen bonds. When collagen is heated, these bonds rupture, leading to a random coil configuration. Thermal denaturation thus results in irreversible shortening and thickening of the collagen fibrils, which later serve as a template for neocollagenesis. The subsequent process of wound remodeling leads to the deposition of new fetal-type collagen type 3, later to be replaced by the more mature collagen type I, as well as neoelastogenesis and the repair of the 3-dimensional elastic fiber network. In fact, the dermis continues to exhibit progressively increasing collagen content with horizontal alignment of fibers, still evident 12-18 months following resurfacing with a CO2 laser. Proper patient selection and pre-treatment care are critical to the success of the procedure. Thus, ablative resurfacing, especially in association with the more aggressive treatment parameters, should be reserved for deeper atrophic scars, whereas patients with milder scarring may benefit sufficiently from non-ablative or fractional devices, as described in subsequent sections. The ideal candidate for ablative laser resurfacing has Fitzpatrick skin type I3, expresses realistic expectations about the procedure, and is able to follow strict wound care instructions. A review of past medical history should be performed with the emphasis on keloidal scar formation, as well as conditions predisposing to infections or poor wound healing. Although a history of recent oral isotretinoin intake in the preceding 6 months is considered by some practitioners to increase the risk of keloidal scarring following ablative resurfacing procedures, other studies appear to refute such evidence. A recent study on the use of multiple topical products, including glycolic acid, hydroquinone, and tretinoin, prior to ablative resurfacing showed no reduction in the incidence of postoperative hyperpigmentation. Antibiotic prophylaxis prior to ablative resurfacing, potentially of most importance with a CO2 laser, is controversial, as various regimens have been proposed but not validated. In addition, such use of antibiotics may lead to the emergence of resistant bacterial strains. The use of antiviral prophylaxis, however, is critical to decrease the incidence of herpetic outbreaks and dissemination. It is typically initiated 2–5 days prior to ablative resurfacing and is continued until full regeneration of the stratum corneum. Preoperative anesthesia for ablative resurfacing using an YAG laser or the plasma skin resurfacing device is typically achieved with topical anesthetic agents or nerve blocks. On the other hand, CO2 laser resurfacing usually requires intravenous sedation or general anesthesia. Finally, an operational plume evacuator is mandatory for all ablative resurfacing procedures. Ablative resurfacing is then performed over the entire affected cosmetic units or, more frequently, over the entire face to avoid the appearance of the lines of demarcation following the healing phase. With the CO2 laser, the entire epidermis is usually ablated with the first pass of non-overlapping pulses. In total, 1 to 3 passes may be undertaken, depending on the depth and the severity of acne scarring. Unless only a single pass is performed, the desiccated debris is wiped off using saline-soaked gauze between the passes. When using YAG lasers, 2–4 μm of tissue depth are predictably ablated for each J/cm2 of fluence. In this manner, the total depth of ablation can be accurately controlled by varying fluence and the number of passes. The desiccated debris does not need to be wiped off after each pass. If needed, pulses may be partially overlapped. While a single pass using lower energy of 1–2 J may be sufficient when treating mild acne scarring with the plasma skin resurfacing device, higher energy settings of 3–4 J may be utilized in more severe cases. In such instances, 1 to 2 passes consisting of non-overlapping pulses may be performed, with the desiccated debris left intact between passes and after the final pass to serve as a biological wound dressing. Postoperative care following ablative resurfacing is generally subdivided into closed and open methods. The closed method utilizes a variety of dressings, such as hydrogels, foams, and polymer films, in order to provide a moist protective environment with a low oxygen surface tension to facilitate wound healing. The open method consists of frequent applications of occlusive petrolatum-based or similar ointments. While the open method is usually sufficient following treatment with a plasma skin resurfacing device, the closed method or a combination of these methods may be utilized after a CO2 and YAG laser resurfacing. While clearly effective, treatment of acne scars with ablative devices, especially at the more aggressive settings, is fraught with potential adverse effects. Erythema occurs in all treated patients and lasts 1–9 months with a CO2 laser, 4–12 weeks with an YAG laser, and 3–14 days with the plasma device. Edema, crusting, and pruritus are common in the immediate postoperative period. Various infections, including bacterial, mycobacterial, fungal, and viral, have been reported following ablative procedures with the CO2 and YAG lasers and, as mentioned previously, the use of pre-treatment anti-herpetic prophylaxis is mandatory. Transient post-inflammatory hyperpigmentation typically occurs in darker skin tones. Delayed onset permanent hypopigmentation, on the other hand, occurs in individuals with skin types I and II, with only rare reports in skin type 3. This unfortunate complication may start as late as 1 year following ablative resurfacing and has been noted to occur in as many as 16% of patients with fair complexion treated with the CO2 laser, and approximately 4% of those treated with the YAG laser. So far, this complication has not been documented with the plasma device. The incidence of contact dermatitis following ablative resurfacing may be reduced with consistent hypoallergenic wound care regimens and the avoidance of makeup and other products until full reepithelialization. Acne and milia formation is fairly common and may be treated with standard acne therapies. Finally, permanent scarring seldom occurs with the more aggressive therapies, such as the CO2 laser resurfacing, but may be related to postoperative infections or improper treatment techniques. Lasers and laser-like devices, traditional non-ablative resurfacing. Non-ablative resurfacing, also known as dermal or subsurface resurfacing, has been developed in response to the prolonged recovery time and the high incidence of adverse effects associated with the ablative modalities. In the treatment of acne scarring, their mechanism of action appears to be similar to that of the ablative lasers, with selective heating of upper dermal water and subsequent collagen denaturation and dermal remodeling with epidermal preservation afforded by a variety of cooling devices. Additionally, various matrix modulators, such as matrix metalloproteinases, may be modified by these treatments and may contribute to the clinical improvement seen with these lasers. The same mid-infrared lasers discussed in the previous chapter in the context of the treatment of active acne vulgaris can also be used for non-ablative resurfacing of acne scars. Patient selection, preoperative care, treatment parameters, and adverse effects are essentially identical to those explored at length in the previous chapter. The reader is invited to review pertinent information from that chapter at this time. Although significantly less effective than their ablative counterparts at improving acne scars, the non-ablative devices are associated with no or very brief downtime and few, if any, adverse effects. 49-50. Relative effectiveness of the non-ablative lasers in the improvement of acne scars appears to be similar. However, only one comparative study has so far been performed. That study demonstrated better clinical results with the 1450 nm laser as compared to the 1320 nm laser. However, somewhat suboptimal parameters were utilized with the latter device. Lasers and laser-like devices, fractional resurfacing. The concept of fractional photothermolysis arose from the perceived need to combine the unequivocal effectiveness of ablative systems with the tolerability and rapid recovery associated with the non-ablative lasers. Since the introduction of the first laser based on fractional delivery of the laser beam, multiple systems have now been developed and utilized in the treatment of acne scars. Table 5. Similar to traditional lasers, they are sometimes subdivided into ablative and non-ablative fractional systems. It should, however, be noted that this distinction is somewhat arbitrarily based on the amount of epidermal damage, since at least some degree of ablation occurs with all of these systems. The first commercially available system utilized a 1550 nm erbium-doped fiber laser to form arrays of columns of thermal damage, also known as microscopic treatment zones. The newest generation of this system is able to penetrate deeper into the dermis and does not require the application of blue dye to the treatment area. Laser light emitted by these systems is mainly absorbed by water, with subsequent heat propagation within the dermis, collagen denaturation, and wound remodeling, which is then thought to account for the clinical improvement in acne scars. Unlike traditional lasers, however, resurfacing occurs in columnar, or vertical, manner, thus leaving intact tissue immediately surrounding each MTZ and facilitating subsequent healing. Non-ablative fractional laser resurfacing can be utilized in patients of all skin types, although special considerations in darker skin tones will be discussed below. As with ablative resurfacing, a history of recent isotretinoin intake is considered by some practitioners to be a contraindication to the procedure. However, no direct evidence of increased incidence of keloidal scarring with this device has so far been documented. Oral antiviral prophylaxis is instituted 2-5 days prior to the procedure in patients with prior history of herpes labialis, especially if peri-orificial resurfacing is planned. Preoperative anesthesia for non-ablative fractional resurfacing is typically achieved with topical anesthetic agents. All makeup is removed prior to the procedure and a petroleum-based ointment may be applied to facilitate handpiece gliding. As the handpiece is moved over the treatment area, the delivery of columns of photothermolysis is automatically adjusted, based on the velocity of such movement. If the velocity is excessive, a higher pitched sound is used to notify the practitioner. Unlike its ablative counterpart, fractional resurfacing may be limited to the problem areas alone without the risk of formation of the lines of demarcation. The percentage of treated area directly affected by the laser beam is related to the total MTZ density, a product of MTZ density per pass and the total number of passes. For the improvement of acne scars, a typical recommended total MTZ density is 1000–2000 per cm2 per treatment session. On the other hand, energy level is selected based on the desired depth of penetration, corresponding to the depth of the acne scars. Patient discomfort may, however, be a limiting factor, thus, the width of the MTZ column automatically increases with higher energy levels. In addition, air cooling, such as that afforded by the CRYO5 device, may lead to greater patient tolerability. Postoperative wound care consists of the use of petrolatum-based ointments or bland moisturizers until complete resolution of epidermal desquamation, with subsequent strict sun protection, especially important in darker-skinned individuals. Multiple treatment sessions, usually 3 to 5, are needed for the best cosmetic improvement and may be administered every 1–4 weeks. As with other resurfacing modalities, patients should be notified of the delayed onset of improvement in acne scars, owing to the gradual nature of post-procedural dermal remodeling. Common adverse effects following non-ablative fractional photothermolysis include transient erythema, typically lasting 2–3 days, and mild edema for 1–2 days. Flaking and bronzing secondary to transepidermal extrusion of concentrated melanin usually begin several days following the procedure and resolve by 1–2 weeks. Transient post-inflammatory hyperpigmentation is common in individuals with darker skin tones. Recent studies suggest, however, that, while both the density and energy of fractionated laser beam may be important, the total MTZ density appears to be a greater determinant of this adverse effect. Epidermal air cooling may also decrease the incidence of post-procedural dyschromia. No long-term or permanent adverse effects, such as delayed onset hypopigmentation or scarring, have so far been reported with non-ablative fractional resurfacing. With the success of fractional technology, additional devices have since been developed. 2 systems, Starlux with a LUX1540 fractional handpiece and a firm, feature handpiece tips with fixed pattern fractionation of the laser beam, as well as built-in contact cooling. As well, the latter system emits sequential pulses of light with wavelengths of 1440 nm and 1320 nm, allowing the use of lower fluences with each of the two wavelengths. Both of these fractional systems may be used off-label for the treatment of acne scarring. However, future prospective studies will need to confirm their utility for this indication. Fractional technology has now also been implemented with other lasers, such as CO2, ER-YAG, and ER-YSGG, Table 5. These so-called ablative fractional lasers may offer greater improvement compared to the previously introduced fractional systems, but are also associated with greater downtime and, potentially, a greater incidence of adverse effects. Although topical anesthesia may be sufficient for some patients, nerve blocks and oral anxiolytics may be required in others prior to such treatments, especially at higher energy settings. Following ablative fractional resurfacing, strict wound care consisting of the aforementioned open method is essential to maintain epidermal hydration and to facilitate healing. Mild to moderate postoperative erythema may last for 2-4 weeks and occasionally for up to 3 months. Transient edema, petechiae, crusting, and oozing also occur in the majority of patients, typically resolving by 1-4 weeks. Although post-inflammatory hyperpigmentation has been documented with fractional CO2 laser resurfacing, delayed onset hypopigmentation seen with the traditional CO2 devices has not been reported to date. It is important to note, however, that the incidence of this and other potential complications will be better ascertained only after prolonged experience with these devices. Following on the success of laser fractionation, numerous other systems will undoubtedly be studied for acne scarring in the next few years. In the end, these developments will likely provide patients with more options and effective clinical improvement of their scars. Treatment of keloid and hypertrophic acne scars. Keloid and hypertrophic scars resulting from acne are similar to other types of keloid scarring occurring from other inciting factors, such as surgery, trauma, and inflammation. As previously mentioned, this type of acne scarring is more common on the trunk rather than the face and also occurs more frequently in patients with darker skin tones. As opposed to keloids, hypertrophic scars never outgrow the margins of the original wound and may regress over time. Although the exact pathophysiology of keloid scarring has not been fully elucidated, abnormal healing response with persistent collagen production, an unbalanced production of collagen type I versus type 3, an anomalous expression of a variety of growth factors, growth factor receptors, and regulators of extracellular matrix have been implicated in its formation. Treatment of keloid and hypertrophic acne scarring is similar to that of other types of excessive scarring and most commonly includes intralesional steroids, occlusion, surgical excision, cryosurgery, pulsed dye laser, and radiation. Intralesional injections are typically performed using triamcinolone, though hydrocortisone, methylprednisolone, and dexamethasone are also utilized for this purpose. Corticosteroids are thought to work by decreasing collagen synthesis and inhibiting fibroblast proliferation. Although recurrence rates could be unpredictable with this therapy, efficacy rates significantly increase when it is combined with excision or cryotherapy. Adverse effects of corticosteroids include epidermal or fat atrophy, the development of telangiectasias, and hypopigmentation. Silicone gel sheets have long been used for the treatment of keloid scars and appear to be especially effective after surgical excision. The exact mechanism of action for this modality is unknown. Although these dressings have to be applied for at least 12 hours daily for several months, their minimal adverse effect profile makes them an appealing option for some patients. Performed by itself, surgical excision or shave removal carries an extremely high risk of recurrence, ranging from 50 to 100%, often leading to even larger keloids. Excision is, thus, commonly combined with other techniques, such as intralesional steroid injection or topical imiquimod cream. The latter is a topical immune modulator that increases local production of interferon alpha, thought to have antifibrotic action. Cryotherapy has been shown to be effective in the treatment of keloids and is thought to alter fibroblast differentiation and activity. As previously mentioned, this modality can also be combined with intralesional corticosteroid injections. The most common adverse effects include dyschromia and atrophic scarring. Pulsed dye lasers are also commonly used for keloids. Laser light has been shown to downregulate the expression of tumor growth factor beta-1, upregulate matrix metalloproteinase 13, and to trigger the mitogen-activated protein kinases pathway. This results in reduced fibroblast proliferation and collagen type 3 deposition. Finally, radiation therapy is usually reserved for the most treatment-resistant keloids. It is very effective at penetrating into the dermis and causing decreased fibroblast proliferation. However, in addition to dyschromia, its adverse effect profile includes radiation dermatitis and possible carcinogenesis, though the latter risk appears to be low. Although multiple treatment options for keloids and hypertrophic acne scarring exist today, current therapeutic modalities are often insufficient to cause full regression when used alone. Combination therapies, as well as future developments in the field, should provide patients with the best chance of good cosmetic outcome. World Medicine Universitet. 2017